In 2013, forensic scientist Philippe Chaulier and visual constructor Philippe Froche digitally reconstructed the face of Maximilien Robespierre, a politician best known for leading the Reign of Terror during the French Revolution back in the 1700s, where thousands of people were executed by guillotine. Based on their findings and a review of historical accounts, they published an article in a medical journal called The Lancet, proposing that Robespierre may have had sarcoidosis. Today, an internal medicine resident and 3 experts get together to discuss the case. What is up, guys? Welcome to PM Rounds, where we explore the wonderful world of internal medicine. I am your host, Chris, and we have 3 exciting new guests that we're going to bring you today. I have with you today Dr. Ruffet, Dr. Broderick, and Dr. Orfanos. And today we are going to discuss the very exciting world of sarcoidosis, and specifically a little historical correlate with Robespierre. So the title of this episode is What Terrorized Robespierre? The famous Reign of Terror gentleman. All right, so before we get to the fun stuff, a little disclaimer.
As always, this podcast is an independent production. The views and opinions expressed here are our own and those of the guests on the program, and do not represent the views of any residency program, hospital, affiliated institution, or employers. This content is for educational and entertainment purposes only and should not be considered medical advice. Clinical decisions should always be made based on individual patient circumstances, institutional protocols, and consultation with appropriate medical professionals.
In other words, we don't know anything. Don't listen to us. Make sure you do your own reading. All right, and with that said, why don't you guys introduce yourselves?
I'm Dave Ruffet. I'm a rheumatologist here at Rutgers Robert Wood Johnson. I'm a recent faculty addition here. I've been here for about 2.5 years. I did my training at University of Michigan, where we spent a lot of time on interstitial lung disease, but not a lot of time on sarcoidosis.
All right, so this will be extra fun today, yeah.
All right, I'm Brian Broderick. I'm a pulmonologist here at Rutgers Robert Wood Johnson. Originally from Jersey. I did my medical training at Hopkins in Baltimore, and then came back here a little bit after Dave. I got here about 1.5 years ago. I've been on faculty since. I do know a little bit about sarcoidosis. So I'd spent some time during my training in a sarcoidosis clinic, so I could certainly share some clinical pearls that I learned there.
Hi, I'm Sarah Orfanos. I'm a pulmonologist here too. I'm also the interstitial lung disease director here, so I'll try to see what I can do on the sarcoidosis topic. You're going to notice I'm not a podcaster at all, but as you can hear, I did most of my medical training in France. And this is a French subject, so I couldn't say no to this.
Absolutely. So this is going to be extra fun today. All right. So before we kind of get into the nitty gritty stuff, and Dr. Orfanos, this is where I'd like to kind of pick your brain as like a French pulmonologist. So Robespierre, who is this guy? And it's funny, I've asked around, right? And I've asked several different residents before doing this podcast, and I get kind of mixed stuff. Some people know who he is. Some people don't know who he is. So are you familiar with this guy, and like kind of what's your understanding of him?
I mean, I have to be familiar with Robespierre. So I was born and raised in France. I went to school in France, and you can't just not know about Robespierre. He's a very divisive figure for us. The thing with Robespierre, what we learn about him is that he had great ideals to start with, like helping minority, the poor, universal suffrage, like a lot of great ideas, but the execution might have been a little too much.
Yeah,
like
no pun intended on execution,
Yeah. So we learned a lot about Robespierre, French Revolution in school. But there's always like the pro-Robespierre, the anti-Robespierre. It's a very divisive subject, I think.
Yeah, no, that's interesting. So do you think, I know you said it's kind of very divisive, but so is the consensus, is he like a good guy or a bad guy? Or, and I know it's history, it's not always easy to break people up into that.
It's impossible to say.
Yeah.
There's 2 teams. There's a team pro-Robespierre and a team anti-Robespierre.
And he's done good and bad things.
He had great ideas, but maybe power got to his head a little. Again, no pun intended.
So I have to pause button here. Sorry to interrupt. I don't know who this guy is, but apparently he was executed and he was power when he was
head shot.
Got it.
Yeah, he got his head. He was like the Reign of Terror guy. Like, so you know how like during the French Revolution they were like guillotining like a bunch of people. So like that was him. Like he was like the main guy that was like leading that.
So he was doing that, but then succumbed to his own execution.
Yeah, so, and it's an interesting story. So I can actually tell you a little bit about like kind of the history. So I'll bring us back. We'll start with the history here. So 1789, we're in France, right? It's a time of like great turmoil. There's like a big crisis going on. The economy is in shambles. So, they recently supported the American Revolution. That kind of helped bankrupt them. There was some bad years on like the plantations and the farms. So that kind of also hurt the economy. There was not a lot of bread to go around. So they called something that was, I believe it was called the Estates General. It was like this group. It's like this kind of state of emergency that's enacted when like basically there's like a dire crisis, right? So they called this assembly together, and it basically assembles like the three main branches: the clergy, the noblemen, and the commoners. And then basically for a while, these three estates, they were meeting up, they were fighting, they couldn't come to an agreement. And eventually the commoners said, screw this. We're actually like greater than 90% of the population. I don't know why we're listening to these noblemen and these clergy people. We're going to split off and we're going to do our own thing. So they kind of split off. They made their own government. And then basically to kind of make the noble branch a little bit more angry, the first thing that they did was they enacted a new rule. They said all taxes as of now are like gone. They got rid of every single tax. And obviously this pissed off the king, because the king, that's his purse. That's where all of his money comes from. So, what he did was, to get back at them, was they were meeting up in like a local building, a local government building. So the king basically sent a bunch of troops there. He said like, oh, we're doing renovations and we're doing all this other stuff. And he locked the building where these like these common people representatives were meeting up. And then so he locked them out. They said, oh, we don't have anywhere to meet now. So what they did was, are you familiar with the tennis court oath? Have you ever heard of that, Dr.
Yes.
Orfanos? Yeah, so they just went to a nearby tennis court and they said, if we can't meet in our government building, we're going to meet in a tennis court. And they took an oath and they said like, all of us here, we're going to like come together. We're going to free the people and make France a better place. Right. So that was kind of 1789. Fast forward a few years, and things were kind of getting a little bit worse. It's a little bit more kind of turmoil. There was wars going on with Austria. And everyone knows that whenever there's like a power vacuum and crisis, that's when someone kind of comes in like almost like a dictator-like figure and kind of takes over and rallies the people. And Robespierre was one of these guys. So Robespierre came in. He was the head of the main political party at the time, the Jacobins. So he was the head and the leader of this party. And they formed something called the Committee of Public Safety. And I think you've probably heard about this when you were kind of in school, Dr. Orfanos. And, this was the committee that was responsible. It was like a wartime executive body. And they were responsible for, catching basically traitors in the ranks. So the way that they did this was, they set up like basically these sham trials, and whoever was basically named a traitor would just go to trial. Eventually they made different rules where like you're not allowed a witness, you're not allowed representation. And there were only two verdicts that you could have in these trials. So if you were accused as like a traitor of the people, there were two verdicts. It was either acquittal or death, right? And this was the rule of 22. And there was no evidence. There was no lawyers. There was like no witnesses. There was none of that stuff. Okay. People were convicted based on moral conviction alone. Moral conviction. So you're like your moral fortitude. And Robespierre was the guy that led this. He was the leader, basically the director of the Committee of Public Safety. And there were some actually interesting things where kind of towards the end of his reign as this leader, he started having like these periodic absences, right? For his first couple of years, he made like 600 speeches, right? And then in his like last year on the committee, or his last 6 months, he only made like 17. And eventually he was retreating for prolonged periods of time to, go to his room, do his studies. And people have basically surmised that it might have been because of his health, actually. Right. So now before we go into Robespierre and how he presented, I want to talk a little bit about how sarcoidosis might present in general. So can one of you guys kind of walk us through? Well, first of all, let's start. What is sarcoidosis? Like, what does that even mean?
So I can take a stab at this first.
Yeah.
And maybe before I do, I just want to say how incredible of a storyteller you are. And as someone who can probably identify France on a map, let alone, obviously, I know nothing about the French Revolution. It's fascinating to learn this stuff. So I'm excited for the listeners of this podcast to also learn.
Yeah.
So I would say the way I describe sarcoidosis to patients, for instance, is that it's an inflammatory disorder, and it can involve any organ system in the body. It tends to end up in my clinic and Dr. Afanos' clinics because it primarily affects the lungs. Over 90% of patients have pulmonary manifestations, and that might present as someone coming in with cough that's chronic, shortness of breath, chest discomfort, and won't go into diagnosis just yet, but those are usually the presenting signs and symptoms that patients have when they come to us.
Interesting. Okay. So it sounds like this it has very general, so like is this a disease that can be mixed up with like other diseases? You know what I mean?
Yeah, I think absolutely. If you watch a lot of doctor shows, especially us that are internal medicine trained, it's one of those diagnoses that we always have in the differential because it can certainly present a lot of different ways.
Yeah.
What I was speaking to is the more classic presentation, but you can think of any single organ system in the body can be affected by sarcoid. So it's something that we always have to consider because it can present in a lot of different ways, even if most commonly it does have a predilection for the lungs.
I see. Okay. How do we usually, in like a clinical setting, how is sarcoidosis usually diagnosed?
I'll say one more thing and then I'll let Dr. Afanos chime in. So
yeah,
I think one of the things that we have at our disposal nowadays is things like CAT scans and things like biopsies. I would venture to guess that these are not things that were easy to come by in the 18th century. But typically the diagnosis today, usually I think of three things: a compatible clinical syndrome, so someone having symptoms that brings them into clinic, maybe some imaging findings, and particularly like lymph nodes that are enlarged in the chest, we'll call hilar lymphadenopathy, and then a biopsy of one of these lymph nodes, and that's a very specific finding on a biopsy that we see under the microscope called a non-caseating granuloma. Oh, sorry, Sarah, I'll let you chime in.
So what I would add is that sarcoidosis is actually one of the hardest diagnoses in pulmonary to make. To these two criteria, there's a third one, is that usually you need to exclude any other differential. So it's usually a diagnosis of exclusion. The biopsy is helpful to find the granulomas, but there's a lot of pathologies and disease that can cause granulomas, inflammation, granulomatous inflammation. So the biopsy in itself is non-diagnostic. So you can never forget the third criteria of ruling out any other granulomatous inflammation. And then there's three, and I think Dr. Rufe would be better at its three syndrome, but there's three syndrome that are helpful if you have them, then you don't need a biopsy and you can make the diagnosis more easily.
Oh, okay.
So Lofgren, Earford, and lupus perennial. I don't know if you want to.
Yeah, no, tell us. Yeah.
So the Earford syndrome is usually parotitis, so parotid enlargement, uveitis, and cranial nerve palsy, which I think when we talk about Robespierre, we're going to come back to Earford again. And then Lofgren, we'll have the arthritis, the erythema nodosum, and then the
hilar lymphadenopathy.
Hilar lymphadenopathy. And then the last one, lupus perennial, is you'll be better at describing this, but eventually there's cartilage destruction of the face if it's untreated. But I don't want to. I'm not best when I'm describing lupus perennial appearance.
Well, the best way for me to describe this is the person who came up with the name lupus perennial should be disbarred, or I don't know what the word is to lose your medical license.
Just lose his license.
Lose your license. Sarcoid, as it affects the face, is not lupus, and it is not perennial.
Interesting. Yeah. I've always wondered why it was called that.
I can't tell you. So
is it because of the mailer kind of distribute? Is that have anything?
It really doesn't even fit in the malar distribution cleanly.
Yeah.
It really affects the nose, and it affects the underside underneath the nose. Whereas the classic malar distribution will be across the bridge, across the top of the nose, sparing the nasolabial fold.
Yeah.
But lupus perennial
I even got a picture of it here. Yeah. Wait, this is lupus pernio, right? This is Wikipedia, so I'm not sure I can trust it. I'll flash it up. I'll flash it up on the pod. Like I'll put it in post. But go on, Dr. Ruffet.
But yeah, so this could be lupus pernio. But what I instruct the fellows is, unless you have a biopsy, you don't know.
Yeah.
So I would say I don't know how much I can trust Wikipedia.
Interesting.
But pernio is another diagnosis. It has absolutely nothing to do with sarcoid. Other name for that is chilblains.
Oh, okay. Wow.
It can be due to lupus, incidentally, not sarcoid.
That's crazy. Yeah.
Somebody's losing their job.
Yeah, no, that's actually a really interesting fun fact. I love that. So kind of going on, and I know, Dr. Ruffet, you said sarcoid is not like your foremost area of expertise, but in general, like when a patient comes in with sarcoidosis, like do you have like an approach to treatment, like generally speaking, like?
Yeah, so sarcoid fits into this category. I usually tell this to the fellows. Everything I'm telling you, I'm just stealing from the people that told me.
Yeah.
And you're going to start to figure out that there are different mindsets to consider when I'm precepting you or how to approach a patient. So I'm not going to use the name, but my program director was just this unbelievable diagnostician. The kind of guy, he would just sit and think, and then he would ask the right questions, and he would just come closer to a diagnosis. He would tell me lupus can do anything, and sarcoid can do more. And since sarcoid is inflammatory but not immune-mediated as we see it, it's not true autoimmune-mediated disease, it's not ours, so we don't really have to worry about it. We just give it to the pulmonologist.
So wait, that's a good point. So is sarcoidosis an autoimmune disease?
So my understanding, as I was trained, without having done any extra work into this, it is not at this time known to be an autoimmune disease.
That's fascinating.
This is an inflammatory disease. The suspicion is that there could be an environmental or perhaps an intrinsic component that the body is trying to fight. Histiocytes are going banana sandwich. But we don't know that this is an autoimmune disease.
Interesting. So I think that's an interesting, because it really is an inflammatory disease. And based on my brief reading, the treatment that we have is primarily steroids, immunomodulators, right? Which kind of makes sense in the realm of this kind of inflammatory kind of thing that's going on. And kind of going off that same realm, does anyone have an idea of what causes sarcoidosis? Do you guys know if there's any cool theories out there, or maybe we just don't know?
Yeah. So I think the short of it is we don't know exactly what causes it. And there are tons of theories about what triggers there are. I think the prevailing theory is that there's some sort of environmental stimulus that the body responds to that triggers this immune response in someone that has a genetic predisposition to developing this condition. One of my former colleague or mentors and then colleague used to describe it to patients as, it's almost like there's a candle in the body and your body is responding like it's a 5-alarm fire to that candle. And that sort of normalized, what was going on in bodies for patients. And it sort of makes sense why we treat this condition, even if it is not an autoimmune process, with things like anti-inflammatory medications like corticosteroids and prednisone and methotrexate and things like that.
For the environment part of it, there's an interesting study that looked at the incidence of sarcoidosis post World Trade Center exposition, and it found a spike in the incidence of sarcoidosis to the people for the workers that were exposed to the dust of the World Trade Center.
Interesting.
So, for sure, we do see an environmental trigger, but most likely, like Dr. Broderick said, in genetically predisposed patients.
Yeah. And from what I understand, I think there's certain populations where it's more common, but we see this really all over the world. Is that right? Or is there one place that is most common? I think it's all over, but I defer to you guys.
Yeah, I think classically, if you read the textbooks would say it's most prominent in patients of African American descent. But the truth is you could see it in any patient. So I would not discount the possibility of sarcoid just based on, what someone's ethnicity is.
Makes sense. Okay, awesome. So I feel like we really got into the basics of kind of sarcoidosis and, what it is, how it might present. So maybe it's time to go through a case. What do you guys say?
Sure.
Let's go.
Yeah, awesome. To go through things, right? So during his career, Robespierre had several intermittent, unexplained absences. In June of 1791, he admitted to the Jacobins in Toulon. that he had not written, he had a brief absence because a period of indisposition brought on by what he said was excess work, which kept me home for a few days. Other absences due to illness on the 19th through the 23rd of September and September 26th through October 3rd of 1792. He was ill throughout February and March of 1794. One quote that he had was, would to God that my physical powers were equal to my moral powers, kind of speaking to his upstanding moral conviction, or what he thought anyway. Across 5 years, he had lectured to either the National Assembly or to the Jacobin club or group about his virtues, about his various virtues. But in the first 7 months of 1794, he made only 16 speeches, when previously he had made hundreds over the course of 5 years. All right. And then we have this great retreat. Right. So if you grew up in France, or you studied the French Revolution, you've definitely heard about the Great Retreat. So at the height of the Reign of Terror, at this point, there were about 60 beheadings per day in just Paris alone. So there's just one city. There were 60 beheadings per day. And then this was totaling about 1,400 people in just over a month. So this was the height of the Reign of Terror. And this was when arguably Robespierre was in his most powerful position, right? He just went and just disappeared for a month, right? He just had a parade. As a matter of fact, he was like making a new religion, essentially, which was like pretty wild. He had this parade where he stood on top of like a cardboard mountain, and this cardboard mountain was like cardboard and paper mache. And he made this new religion, and he was like the leader. And then he dressed himself in like all like these blue robes and decorum, and he like descended the mountain, and almost saying that like insinuating that he was like a godlike figure, like the head of this new religion. Anyway, so like following this, he had this great retreat where he kind of just disappeared at the height of his power for about a month, right? And there's a few theories about why he kind of retreated so long. So one was maybe because following his new religion, and it was kind of a failure, and people were making fun of him after that. Some people believe that he was just embarrassed, so he just went to live with a local Parisian noble family and kind of just wanted to hide out for a month. Other people believe that he was trying to wait out his enemies, right, and see who would rise up and try to take his place while he was gone, so that when he could come back, he could know who to eliminate, right, who to behead. And then there's another theory where he was maybe just conducting investigation of prominent committee and convention members, coming up with a list of who he wanted to kill ultimately, right? And then the last theory is that he was sick. He was sick, and that's why he disappeared. So let's go through the case of this gentleman, all right? So he was a young man in his 30s. Generally, he appeared thin. He was small in stature, perhaps maybe 5'3". He was relatively frail appearing. He was pale. He wore thick glasses, and some described him as being jaundiced. They said choked with bile is what the way that they described him. And this was corroborated by several sources. He had pockmarked skin, and I'm going to pass this around in case you guys just kind of want to take a look. We'll kind of go through how they reconstructed those in a second. But he had pockmarked skin. And he was described as being red in the face with kind of blotchy and inflamed skin, especially in the months before his death. His voice was described as soft or weak. Moving into other systems, he had frequent nosebleeds. And this was corroborated by a single man, Pierre Villers, who served as Robespierre's secretary for several months during 1790. He said every night he, quote, soaked his pillow with blood. I can take that back. He had these strange like facial twitching and tics. So people would describe that he had like this kind of like twitch, especially in his cheek, especially when he was up speaking. And this was corroborated by several accounts. And it's unclear if this represents a true neurologic issue or something more like psychosomatic or just like a facial tic. His doctor reported that he sometimes experienced fatigue, weakness, frequent headaches, tremors. And of note, he had skin lesions. So he had one lesion on his leg that the doctor would come tend to regularly, and he would basically like wrap it in a fresh bandage every day or every other day. So he had this strange skin lesion on his leg with what we can say is poor healing, right? His doctor was this guy named Dr. Joseph French pronunciation, Dr. Souberbiel. Did that sound right?
Super bio, yeah.
Oh, okay. So I was close.
Sounded better when she said it.
Yeah, I agree. And so he reported it as like a varicose ulcer on his leg. That's how he described it back in the 1790s. All right. And as a matter of fact, the doctor was tending to this wound on his leg up until basically the day when Robespierre was beheaded. Right. Now, I know everyone was curious, why was Robespierre exactly beheaded? And this is actually another interesting kind of historical correlate as well. So when he came back from his Great Retreat, and this is funny, but in kind of morbid way. So he came back from his Great Retreat, right? He was missing for like a month. He goes like to the podium, he stands before the Committee of Public Safety and all the people, and he says, I got a list of names, okay? The past month, I've come up with so many traitors, I've researched so many traitors, and I have a list of traitors. Many of them are among us, who are traitors to the French Republic. The thing was, he didn't name any of the names, So he went before this body of people. He has a reputation for guillotining people, right? For being basically a very controversial figure, killing a lot of people. And then he comes before everyone and he says, I got a list of treasonous people, and I'm not going to say who they are. So obviously everyone was very scared. Everyone was thinking I could be on that list. Because this guy was known to behead his own friends if he thought that they were being unfaithful to the ideals of the French Revolution. So what they did was they came forward and then they basically decided, no, actually we're going to behead you. So they arrested him, and within 2 days of arresting him, he was killed. And he actually attempted to commit suicide beforehand. So what he did was he actually, reportedly, and this is much contested, some people believe he was assaulted or shot, but he shot himself, and people believe that the gun misfired and it hit his jaw and blew his jaw off. And he actually was tended to by a doctor after he was arrested, and his jaw and his head was held together by bandages, right? And then these bandages weren't removed until he was walked up to the guillotine and beheaded. And it was a very grotesque kind of sight. There's many very graphic accounts of this and what happened,
And release of death for that guy.
Yeah, yeah, no. And people say that when he was walking up to the guillotine, it almost looked like he was relieved, is what they were saying. He's very solemn.
30-year-old.
Yeah, exactly. And it was crazy. It was crazy. So. So what's interesting was, so they beheaded this guy, right? And his head went into the pile of, other heads, right? And then there's this woman named Madame Tussaud. Have you guys heard of Madame Tussaud?
Yeah.
Yeah, where are you? Do you know?
I'm from New York, and we would never go there, but it's a tourist attraction that you walk past.
Yeah.
Madame Tussauds wax museum.
Exactly. So she had this wax museum, and she was weird. I guess she was a good businesswoman, or maybe people asked her to do this, but she was I'm going to take this guy's head and I'm going to make a mold of it. Right. So she apparently found his head in a pile of other bodies, and then she made this wax mold. Right. And you can take a look one more time there. There's that wax mold there. I think it's in figure B. And what's interesting about that wax mold is if you look at the jaw is kind of perfectly intact. Right? So the theory is that Madame Tussaud, assuming that this is the real head of Robespierre, which we don't know for sure, we just have to take her word for it, right? She must have reassembled the jaw in some way, because we do know that his jaw was kind of blown off, right? And then if you look in 2013, this team of forensic pathologists essentially, they were able to take this mask, this death mask. They scanned it, and then what they did was they recreated what his face, or what they believed his face would have looked like. And you can see it right there, and I'll flash this up on the big screen. And this was stunning for a lot of people, because take a look at this guy and take a look at the guy in figure A.
This guy looks like a Bond villain.
Yeah, so he's kind of scary looking, and this was very, like Dr. Afanos was saying, this guy was he's controversial, but he's beloved by some people. And then they said you're making him look so evil. Because in this portrait, he looks, and I'll put this up on the screen, he looks like such a gentle guy here, and then, this is how they reconstructed him, right? So this team of forensicists reconstructed the face, and based on the findings here, and what we know about how he presented back in the day, they were saying that this guy might have had sarcoid, right? So I'm going to I know we talked about a lot, so I'm just going to re-sum up the case a little bit and just talk about the pertinent stuff. So, man in his 30s, had these vague constitutional symptoms, right? He was kind of thin, kind of frail. He had frequent nosebleeds, facial twitching. He had this kind of jaundiced, unhealthy appearance to him. He had these kind of tremors, skin lesions with poor healing. And then probably most notable, he had these kind of strange facial findings and, reported red blotchiness. So let's kind of go through some of these symptoms and figure out, how would you guys build a differential for this guy? Like, just, feel free to just kind of shout out what you might be thinking here.
I'll just say as a blanket statement, like my mentor said, sarcoid can do more than lupus. It's going to be very easy to try to choose one core process to explain everything. This guy's had a lot of stuff going on in his 30 years. He probably had more than one thing happening over the course of time, and probably cumulative. The thing that in this case, when I have somebody with multiple issues and I'm looking to see, is there one core issue or are there multiple? The Occam's razor is just looking for parsing on. Could there be? And sarcoid can do any of this, but it's not clear to me how it would lead to excessive bleeding.
Fair enough.
If he had a coagulopathy, if this guy had scurvy, it would be easily explained by somebody who just had a dietary restriction during famine. I can see that. But I don't see sarcoid leading to diffuse nosebleeds or an obvious cause of jaundice from hemolysis.
Yes, fair.
He had an infiltrative disease of the liver, and he had a bile accumulation, perhaps, but bleeding would stand out as me is not easily explained.
Fair enough. Yeah, kind of going off the liver there. From what I saw, liver involvement in sarcoid is not as common as like pulmonary involvement. I think we see pulmonary involvement in 90% of cases or something. And that's, I think, why the pulmonologists are so like kind of involved in managing this disease. But I think we see liver involvement in as many as 30%, but in most cases, it's asymptomatic in most cases. Right, yeah. Unless you get, I guess it's like an infiltrative, granulomatous kind of destruction of the bile ducts or something, or maybe just a mass effect kind of thing. And then that could lead to jaundice. Is that plausible?
Could.
Okay, could.
But I think,
but rare though, right?
Exactly.
Okay.
I don't know that, persistent, bile levels that are so, it's just so active in him that he's walking around
like yellow, yeah.
Like that really screams to me liver failure.
Fair enough. Interesting.
Yeah. I will say in the patients that I've taken care of that have liver involvement of sarcoid, it's usually asymptomatic, and it's usually detected just on like routine, chemistry panel where we actually see elevations in AST, ALT, like classic transaminase elevation. I don't know if I've ever seen just elevated bilirubin from sarcoid alone, but I think you're absolutely right that sarcoid can do everything, and it can certainly, you can come up with a case where maybe it has, intrahepatic biliary involvement. Maybe it does lead to some, biostasis and leakage of, bilirubin into the blood. So you could come up with a situation, but I think each one of those symptoms you listed probably has a differential that's very, very long.
Yeah, fair enough.
So I think coming up with a unifying diagnosis is going to be a challenge in this case.
Yeah, no, absolutely. What about, so I guess going through the other stuff, like, more low-hanging fruit, like the fatigue, the diffuse weakness. This could be caused by really, anything, including sarcoidosis, right? What about these facial twitch? Because I found this interesting. Facial twitching and tics. So could that be like a cranial nerve 7 kind of involvement of sarcoid? What are the odds of that? What do you guys think of that? Like, again, is it just plausible, but, not necessarily probable?
It sounds like he has a high-stress job.
Fair enough.
I've never seen, so here at Fort syndrome, I've been looking for this diagnosis. Haven't seen it.
Yeah.
We just actually had a patient, no HPI disclosed, but recently had a patient who had fever that could not be explained, had bilateral parotid swelling, but no uveitis. And I'm looking for the pattern of disease, and it's just not obvious. It's hard to make that diagnosis. This person did not have a clear seventh nerve palsy. But I don't know. I can't remember seeing a seventh nerve palsy since medical school.
Yeah, I've never seen it here for syndrome. But you can get CNS involvement of sarcoid, so you can imagine that there can be cranial nerve involvement too, and you can have a different process that's not, pathognomonic for sarcoid that can also lead to neurologic findings.
Interesting. Okay. The soft, weak voice, I'm not really convinced that that's anything, maybe that was just more of a personality thing, or, that was just kind of, just how he talked.
Was that before or after his jaw got blown off?
I think that was both, actually, but okay. Primarily before. I think that's when he was making his speeches. The tremors, again, what do you guys think of tremors in sarcoid, related, unrelated, nonspecific?
Yeah, I think small fiber neuropathy certainly happens. Mm-hmm. Difficult to diagnose. But for me, that looks more like a distal polyneuropathy. I don't know, that presents with a tremor.
Fair.
Probably with a loss of sensation, perhaps weakness.
Yeah, gotcha. What about these skin lesions that he had? So I know sarcoidosis, erythema nodosum, and I'll put a picture up on the screen. That's like one of the common ones, right, that we see with it?
So erythema nodosum lesions, definitely, and then lupus permanent.
Yes. So what about, could it sometimes present with like an ulcer, or like a kind of like a more papulopustular or ulcerative lesions? Or is that really not as much a thing? Do we really just see the more classic like nodular kind of presentation?
It's a good question.
Mm-hmm.
I've seen lupus permanent, but I've never seen destructive ulcerative lesions.
Fair enough. Yeah, with sarc. And from, spoiler, I looked into this as well, and from what I understand, it's like a lot less common. Sarcoidosis, typically it presents much more with like the erythema nodosum rather than especially an isolated like skin lesion. I'm not as convinced about that one. And, an interesting thing here, when I plugged in like the differential, when I plugged in like all the findings, right? I plugged in, the jaundice, the fatigue, the constitutional symptoms, the nosebleeds, and I plugged everything in, but I accidentally left out the lupus pernio part, the facial findings, right? And then when I plugged this into open evidence, the diagnosis that it gave me was actually lead poisoning, So that's what it told me. And the way that it explained this off was it was saying that like lead poisoning, it could cause the coagulopathy through platelet dysfunction. It can, it can potentially cause the jaundice through like hemolysis and that causing the jaundice perhaps. It said it could cause like the tremors. It could cause, poor healing of like the, wounds, poor wound healing, and I believe that's because of lead infiltrating like the connective tissue. So what's interesting is that lead poisoning actually like explains a lot of what we're looking at. But again, I forgot to plug in the facial findings, right? So, and then immediately when I plugged in, I said, what if this patient, and this was into open evidence, by the way. Open evidence is like a major AI that we use in medicine. It's like ChatGPT, but for doctors. So I plugged in and I said, what if this patient also had lupus pernio? And then instantly the AI was like, it's sarcoidosis, So let's say, put yourself in the shoes of this guy's physician back in the 1790s. Let's say
I don't want to do that.
Yeah, I don't want to. Yeah, I don't want to do that. It was a scary time. And I'd like to hear from each of you. Like, let's say hypothetically, he did look like this. He did look like this guy. And, we don't have the advantage of having like biopsies, pathologists to review slides. We don't have the advantage of, they didn't have labs back then. Would you be comfortable landing on sarcoidosis as your presumptive diagnosis for this guy if we could go back in time?
So, Chris, there's an interesting backstory for this patient. Is that Robespierre wasn't very independent, so he liked to live in other people's houses and place.
Yes.
So he used to live with a mother and a daughter, and he was pretty healthy when he was there. And then at one point, his sister came and said, you're too old for that. You're too powerful. You need your own place. And she moved him to a new apartment. And that's when his health deteriorated. So I can buy the lead poisoning just because of the
interesting. Like, maybe it was in the pipes, I think some of their like, drinking ware had it then too. So you seem to favor the lead poisoning then.
It's possible when you've been on pulmonary and interstitial lung disease clinic, right? And we try to be very thorough about environmental occupational exposure. So if Robespierre walked in and told us this story of switching to a new place and becoming very sick, then that might have been on the differential.
Yeah.
Then, yeah.
And lead was like in everything back then, right?
Mhm.
Was it in the guillotines?
I have no idea what the guillotine blade was made of. I actually have no idea. You know, I don't even. I wonder if you can even. I'm going to Google that. I'm going to look that up. You know, but hopefully not. You know, it's a little less. One less thing to.
Yeah, I don't know how many people are in manufacturing.
Yeah, I don't know. I think I looked this up at one point. The last guillotine was in like the France, because they used it for a while. Like after, I want to say it was in like this. No. You might know.
Sarah's got one in her office. I've seen it.
It's not like that. I promise.
I've
It's not
never
like that.
used it. Yeah.
So I think they used it into the 20th century, didn't they? Like.
I haven't kept track.
Okay, yeah, no, I mean, it's not a common stat. I'm gonna put it in the show notes.
You don't have to incriminate yourself.
Yeah,
Sarah.
fair enough.
I left France. You can't find me.
Yeah, no, but they used it. They used it pretty late, which is interesting. But okay, so you're kind of landing on lead poisoning then, especially because of the environmental switch when he switched to the new place, and then his health kind of deteriorated more after that.
Yeah, I mean, it's impossible to make a diagnosis.
Yeah.
But, yeah.
Could you have made, because we did talk about some of the non-biopsy, like, kind of ways of making the diagnosis, like Hereford and Lofgren. Lofgren was the other one, right? Okay, yeah. Could you potentially see yourself making one of those clinical diagnoses in him, or just not enough data? Like if you had the chance to examine him, you think?
No, what would concern me more is, because as we said before, he had some signs of liver failure.
Yeah.
Most likely not from sarcoidosis, since it's very rare, as we said.
Mm-hmm.
So instead of like running after the diagnosis of sarcoidosis, and that might be the critical care part of me,
Mm-hmm.
I would worry about his liver and start
Fair enough, yeah.
work up about his liver failure. Yeah.
Absolutely. And then what about you, Dr. Broderick?
Would I make a diagnosis of sarcoid in this gentleman?
Yeah, like how do you feel strongly about this diagnosis, or do you feel like we should be looking somewhere else?
So I don't feel strongly about the diagnosis. I think my approach to any diagnosis that we generate, I think it's always important to start broadly and then try to assess out what's signal versus what's noise. And I think in a case like this, when you have such a wide array of non-specific symptoms, you really want to try to zero in on something that could be suggestive of something that's more narrow in terms of diagnosis. So I think the focus on the skin in this case perhaps is important because generalized weakness, maybe like a bleeding diastasis, like all these things, a lot of different things can cause it. But if there's pathognomonic skin findings, the big caveat here is I'm no dermatologist, and when I have skin findings that I don't know what they are, I usually call the dermatologist. I don't know how many dermatologists were in 18th century France, but I think that would probably be, in terms of focusing on a background diagnosis, what I would focus on. But I totally agree with Sarah. If this guy was in my clinic and he is jaundiced, I'm focusing on the life-threatening causes and liver failure and going down that diagnostic pathway. So I don't feel confident making a diagnosis of sarcoidosis in this man. I think it's something we could certainly entertain, but I'd like to get more history, environmental history,
Agreed.
Personal history, without angering this gentleman. So he cuts off.
Yeah, I don't know. I would be kind of nervous if I was this guy's like doctor, honestly. Like if I rubbed him the wrong. I don't know. Then again, maybe since you're his doctor, you're like the most safe person in a way, because it's like you're so close to him and he's so dependent on you that like he wouldn't want to like get you to.
I'll refer him to you.
Fair enough. Yeah.
In his personal position.
Yeah.
I'm getting like Nero, McCarthy, Stalin vibes from this guy.
Yeah.
He might be a revered figure, but right now I'm scared looking at this guy.
Yeah. No, I think especially with like his his facies. So
he needs one of those lines across his eye with an eye patch, and he needs to say Mr. Bond.
Fair enough.
Yeah, the other thing we didn't talk about with sarcoid that I think is important to mention also is that most patients actually go into remission from disease. So I think the last time I read about this, it was like over 50% of patients who are diagnosed with sarcoid eventually go into remission. So I think our perception of this is a little bit skewed because most patients that we encounter with sarcoid are the ones that are in clinic a lot, they're in the hospital a lot, and they have progressive disease and advanced disease. But by far and away, most patients, like for example, someone that has just like asymptomatic hyaluronephritenopathy, it often regresses on its own. And goes away.
So that is an interesting point. Most people with this disease do fairly well, right? Yeah, no, that is a good point. I mean, and if sarcoid was the case with this gentleman, he didn't do well. But again, there's a lot of different possibilities there. And I forget, Dr. Ruffey, did you weigh in yet on what your verdict would be in this case, or?
No, usually I have to say, I really enjoy this kind of discussion. This is, when not making a pitch for this, but
I'll make the pitch.
So people go into academic medicine for a couple reasons. One, we don't want to work as hard as people in private practice. But two, you get to sit down with a cup of coffee and very bright people and just think. And it's a little bit like fantasy baseball. I'm not a sports guy, but we get to do this with medicine. And so I really enjoy this. So thank you for having this.
Of course, yeah.
So when I think about these kinds of multi-system diseases and you just don't know, is there one process or many, and what is the most likely? I use a mnemonic, and this is insulting to the ICU people. I use MICU, where I did training. It was medical ICU. And that's the mnemonic for multi-system disease that tends to be on the more severe end. And the M stands for medicine. You're going to forget medications will cause multi-system disease. It's not something you can easily detect on the lab, imaging, or a special study, and it will cause many problems unless you take a great history. So think of medicines first. This guy probably was not taking...
Yes.
Whatever it is that could cause this. But
his main thing, do you know what his main thing was? I actually forgot to say this. Oranges. That was like the main thing.
He didn't have scurvy.
There goes scurvy.
So I forgot about that. So scurvy less likely. But this guy was like a big orange guy. Like apparently they said that like you could tell where like, he was, where he was working, where he was eating. You just look for the orange rinds. They would just be like on the desk or whatever. So like he was
fascinating.
Yeah, and his doctor was like, you got to eat more oranges. Like this will help you. It was like that. I think he did that, like wound care, obviously, and I think there potentially might have been like some bloodletting, but I have to double check. I'll put that in the show notes. But go on, Dr. Ruffey.
So there's medications, probably not relevant here, and then infection. Infection is infinitely more common than all the other causes. It's just more likely. There are no antibiotics at this point, and I look at his face and I would say, are those syphilis marks? I don't know. Maybe.
Yeah.
It could be. Maybe this guy had cowpox or I don't know, anything. But infection would be at the top of my list well before an autoimmune process, or in this case, an immune inflammatory process.
All right, and we're back after just a brief interruption. Dr. Orfanos had to step out for a little bit, so we'll finish up with Dr. Ruffey and Dr. Broderick. All right, Dr. Broderick.
Yes. No, the last thing I said was, I was just looking at the picture of him when David said he was in his 30s. It was striking to me that he looks much older than 30. So I think that's another maybe clinical feature of maybe the underlying diagnosis.
Yeah, no, absolutely. And I should have put that in my kind of general constitutional stuff. Patient appears older than stated age. And I think it brings up another point, and we'll put this up on the big screen too. But we don't even know for sure. Like we're taking Madame Tussauds word for it with this cast, right? But we don't have direct confirmation that, she could have, for all we know, casted a random beheaded person for this. This might not even be his face. No, it's true. And people have actually voiced that concern. Like, what if this isn't even him? Like, she says it's him and we take her word for it. But like all these years in the wax museum, we could have like the head of like some random person, So I guess for this to kind of line up with sarcoidosis and, for us to be able to call this like, really rely on these facial findings, we're making a lot of assumptions about like, one, if this was Robespierre, did she tamper with the features, right? That's step one. And then number two, was this even Robespierre to begin with? So I think that also leaves us with some kind of interesting things to keep in mind. And, I would be inclined to agree with kind of the consensus of what I feel like we found on this panel, which is that there's a lot of other concerns that I would have if this patient kind of presented. And I'm not really 100% sure I would be confident in a diagnosis of sarcoidosis in this case. I think it's certainly on the differential, and it's certainly possible. But, I think there's a lot of other things that we could potentially be looking at. But, things like, infectious, TB, leprosy, we could even look at like, vasculitis perhaps. Those can present in really weird ways. Cancer, malignancy, paraneoplastic, various poisonings like lead poisoning we discussed. So there's a lot of different theories that we're looking at here with him.
A general comment, we get patients that have multisystem disease all the time, and our job is just to call bullshit and say, this is not an autoimmune disease. It is just, and that's where really internal medicine starts.
Yeah.
And so the story you didn't ask for, but I tell, my first year of rheumatology was the hardest year of any medical training. And it was because I was good, but not good enough for internal medicine. And so I'd spend the day learning internal medicine, and then I'd spend the night reading about rheumatology.
Yeah.
And it's because you really have to know all these other diseases. What else could this be? And then once you can't explain anything else, then you start talking about autoimmunity.
Yes.
And you're looking for a chronic relapsing picture. And sometimes it's just, you don't have enough information at the time that you're seeing the patient. So the short answer is I see a patient like this, and I just say, yeah, it needs to be an iconic picture, or I'm calling BS.
Fair enough.
Yeah, and I'll piggyback on that. I did spend a lot of time in a sarcoidosis clinic, and one of the things I noticed the longer I was there is that we were often undiagnosing sarcoid more than we were actually diagnosing sarcoid, because we got referrals from all types of patients and physicians with lymphadenopathy, for instance, and even non-casein granulomas on biopsy, but the things that can cause non-casein granulomas, the list is vast.
Yes.
And Dr. Orfanos had said earlier, which is really important, is that you really have to rule out all these other things that can lead to these histopathologic findings and also these clinical findings. So more often than not, to Dave's point, going back to taking a really good history, making sure you're not missing infection, other diagnoses that can mimic something like sarcoid. And then if you, at the end of the day, you come back to sarcoid after you've ruled out all those other things like infection, like cancer would be, like lymphoma would be a big one, for instance, then you can arrive at a diagnosis of sarcoidosis and think about treatment if the situation's right.
If you guys, let's say you were, I know we don't like to think about being Robespierre's physician because it can be kind of scary, but do you guys, and I'm putting you on the spot here, if you were transported back in time and you were there, like what would you do? Would you just would you have given him the oranges, or would you have would you have tried to figure out something else? I don't know how common lead chelators were back then. I don't know how I would have even found those. Do you guys have any ideas how you would have helped this guy?
I think the oath.
Try to escape to a different country.
Yes. I think the oath should be timeless, but when your life is on the line, I'd be giving this guy snake oil and say, "This is it. You're done. You're good."
Fair enough. Yeah. Fair enough.
Do no harm to me.
Yeah, no, that's a good point. That's a good point.
I think another concept here that's important is we always think of medicine as we figured it all out. Now we have it, and then people start asking more questions. All right, maybe we don't have it all figured out. 30 years ago, if I said this patient has IgG4 related disease, you'd be like, I'm not an immunologist. But now if you say that, that's going to be on your internal medicine boards.
Yeah, yeah.
And the idea is that the more we look, this is the terrible joke of the guy who's looking for his keys in the back alley. And the guy comes and he's looking and he says, "Where'd you lose your keys?" And he goes, "Oh, over there in the dark." He goes, "Well, why are you looking here?" He says, "Because the light's better." The best physicians, or the ones that make big transitions, they don't have to change infrastructures. They just move the light.
Yeah.
And so when we get a better way of finding a peripheral biomarker or solidifying, all these cases with different eponymous names have one unified diagnosis, and that's because there's a shared pathology. That just took a lot of hard work. People doing biopsies and saying, what's the shared feature? So IgG4 related disease is now increasingly recognized simply because we have a codified system of saying, what is this? And probably was similar for sarcoid in the early stages. I think we have clinical features where we don't do a biopsy, but I feel confident this is Hugh-Forts, or this is Lofgren's, or this is lupus pernio. But once you get better technology, you get better x-rays, and then that moves to CT, and then you get better ways to do a transbronchial biopsy. The diagnosis is easier, the prognosis is better, but there's probably 100 of these out here, and we're not capturing that information yet because we just haven't shifted the light.
Yeah.
So all these diseases we can't.
That's a really cool story. I like that.
I was a philosophy guy, so that's a philosophy joke.
Okay, yeah.
That's epistemology as it relates to metaphysics.
Mm-hmm. No, I like that. That's awesome. For sarcoidosis in general, who usually takes the lead on this? Is it pulmonologist? And then rheumatology sometimes kind of weighs in for an inflammatory component? Or do you really say, Dr. Ruffey, I want Dr. Broderick to just kind of take the lead on this?
Are you asking me?
Yeah, either of you.
Yeah, I think the answer is it'll be very institution specific.
Really? Okay.
And it'll be specific to not only institution, but community versus academic. It'll probably be managed very differently. I've seen it where there's multidisciplinary sarcoidosis teams that, maybe is headed by a pulmonologist, particularly if there's, lung involvement, but also a neurologist that's involved if there's CNS sarcoid, but also a dermatologist if there's, skin manifestations. So I think it will vary significantly depending on what the disease manifestations are and whose expertise lies where.
Mm-hmm. Yeah, absolutely.
And I think this dovetails with the concept of something like psoriatic arthritis. Who owns this? And the question is, who did the patient see first? And who treated? So there was a nice letter to the editor from a dermatologist in a rheumatologic paper, and I think the title was "You're Welcome." When dermatologists become more comfortable prescribing the medications we would for arthritis, for their dermatologic disease, they never show up in our clinic because they're already being treated.
Yeah.
And this is sort of I wouldn't say prophylaxis. There probably is a subclinical component of psoriatic arthritis, but it's the skin psoriasis that's really bothering them. But they get treated with the TNF-alpha inhibitor and they don't show up to my clinic. It's a dermatologist saying, "You're welcome." So if you have an active pulmonologist who's saying you have, I couldn't tell you anything with the staging, with the staging of, if you have hyaluronopathy or just...
Yeah, it goes stage 1 to stage 4. Hyaluronopathy being stage 1.
But at some point, a pulmonologist might say, "I'm treating you even though you don't have clinical features like pain, weakness, shortness of breath. I'm going to put you on a medication." They may never show up to see me because of arthritis.
It's incredible.
Yeah.
It's awesome. Do you guys have any more kind of closing remarks, interesting stories, closing remarks about sarcoidosis or patient experiences in general? Anything that surprised you? It's a good opportunity to get on a soapbox if you have one.
So I do. We have a shared ILD clinic with Dr. Orphanos, and we see a patient, not disclosing any HPI, but this is a young man who, by mom's report, was in his complete normal state of health. Everything was fine at the age of 30. And then within 1 year, he's diagnosed with schizophrenia. He's identified coming into the hospital twice with adrenal insufficiency. He's identified with, they're calling it sarcoidosis. This guy has several sites. So it has a transbronchial biopsy. It has an axillary lymph node, non-caseating granulomas. For the life of me, I don't know if this guy has one unified diagnosis. It's entirely possible. So when I write that first H and P, I'm sitting there saying the only way to attack this is like I'm a third-year medical student. Saying I'm going system by system, and I'm saying what is most likely, what is possible, and what have I excluded. And it's just suspected sarcoidosis, or in this case, I would call it confirmed. I'm saying hematologic, oncologic, infectious, hepato-GI. And I'm just saying, what's possible? What are we missing?
Yeah.
And this takes forever. I can dictate my notes on a scleroderma patient, and it'll take me 20 minutes.
Yeah.
I spent 3 hours just thinking about this, and then it took me another 5 hours to write the note. It's insane, but that's how difficult sarcoid can be.
Yeah, I'll echo Dave with the same things. I think we have a similar approach to complex patients, and that really questioning everything you read about a patient. One of my biggest pet peeves in the chart is when there's these enormous long one-liners that have these diagnoses that may or may not be confirmed, but they get carried forward in the chart because people find it easier. Granted, we're very busy. We see lots of patients in the hospital. We spend a lot of time and effort in documentation, even if that's not what brings us most joy in medicine. But we're doing patients a disservice sometimes when we don't dig further into some of these diagnoses. And I think sarcoidosis is a great example of that. So when I see a diagnosis of sarcoidosis as a lung doctor, I'm always going back to how was this diagnosed, right? Was there a biopsy done at any point? What other organs were involved if we did have a confirmed diagnosis of sarcoidosis? And it's one of those diagnoses that we actually, because it's so hard to diagnose, we hedge a lot. Even on patients that we have a non-casein granuloma biopsy that have a consistent clinical presentation, everything is screening sarcoidosis. Some of the guidelines, like from the ERS and ATS, they'll still label that as probable sarcoidosis, just to leave a little bit of gray area in case this is something else. And we still might treat those patients as if they had sarcoid, and obviously we're going to follow them closely. But I think it just shows you how difficult it can be to make these diagnoses in real time with all the tools we have at our disposal, let alone hundreds of years ago, and trying to make it retrospectively.
Yeah. But the retrospectives are really fun, though.
Oh, yeah. So this was great. I'm really glad you invited me to do this. It's fun.
Well, thanks so much for coming on the show, everyone. So we had Dr. Rufanos, who stepped out, Dr. Broderick, and Dr. Ruffet. This was What Terrorized Robespierre, the retrospective diagnosis of sarcoidosis, which we are largely kind of not super in favor of, which is interesting. So we gotta kind of post our opinion on that Lancet article that we have that's out there that first kind of came up with this. So thanks so much for tuning in. This was PM Rounds, and I hope to see you guys next time. Thank you, and thank you guys.
Thanks, Chris.
desk. You've done this before. This looks.
No, this is the first time.
Is it really? This is super impressive.
Yeah, it's fun, right?
Holy shit.
Yeah.
Oh, no blue words. We'll stay away from blue words.
I can bleep them out. I can bleep them out. You know, so just be yourself, Dr. Ruffey. Okay. If you're feeling spicy and you want to go for it, then go for it.
Sometimes I can't help it.
Yeah. All right, I got my water here. No, my voice is gonna go dry. All right. Do a quick clap. That helps link up the audio and post. So, and then I just need my disclaimer because we don't want to get sued by anybody. So I always start with a disclaimer.
I appreciate that.
All right, you guys ready?
Yep.
The person who came up with the name lupus perennial should be disbarred, or I don't know what the word is to lose your medical license.
So wait, that's a good point. So is sarcoidosis an autoimmune disease?
So my understanding, as I was trained, without having done any extra work into this, it is not at this time known to be an autoimmune disease. So people go into academic medicine for a couple of reasons. One, we don't want to work as hard as people in private practice. But two, you get to sit down with a cup of coffee and very bright people and just think. And it's a little bit like fantasy baseball. I'm not a sports guy. But we get to do this with medicine. And so I really enjoy this. So thank you for having us.
Of course, yeah.